Okay. Good afternoon, everybody. My name is Stephanie Verna, and I'm here as the Research and Program Manager at the Injury Prevention Research Center at Emory. And so this is our third installment in our data literacy series in collaboration with the Georgia Department of Public Health. And so our first session, we talked a little bit more about Georgia's tool for public health and public policy data analysis, also known as OASIS, or the Online Analytical Statistical Information System. And our second session went over EMS and trauma data sets. And so both of those videos are located on IPRCE's YouTube page, and it's under the IPRCE DPH Data Literacy Series playlist. So right now we have two that are on there, and we'll upload them as we go through, and the session today will be uploaded there. So for today, we have Elizabeth Blankenship and Adon Oviedo, who are both epidemiologists with the Chronic Disease, Health Behaviors, and Injury Epidemiology section at the Georgia Department of Public Health. And they're going to present to us a little bit more about Georgia's Violent Death Reporting System, also known as VDRS, and the Firearm Injury Surveillance through Emergency Rooms, also known as FASTER, Georgia's approach. So while presenting, if anybody has any questions, if you can go ahead, you can pop it in the Q&A box, and we'll get to it at the end. And then we'll get to them as soon as we can. So we can get started. Let me turn it over to our first presenter, Elizabeth Blankenship, and she is going to present on Georgia's Violent Death Reporting System. And so, Elizabeth, you are up, and thank you so much for being here.
Awesome. Thank you so much. Okay, can everybody see my screen okay?
Yes, ma'am.
Wonderful. Thank you so much for joining today. Like Stephanie said, my name is Liz Blankenship. I'm the Georgia Violent Death Reporting System epidemiologist at the Georgia Department of Public Health. And today we're just going to kind of give you an overview, and we have a little outline for you of everything that we'll talk about. So we'll just talk about an introduction. What is the Georgia Violent Death Reporting System? That is a whole lot of words, so I'm going to call it GA-VDRS from here on out. We'll talk about how we collect our data, what data elements we can provide, how things to keep in mind when you're interpreting our data, as well as the limitations to our data, and how you can access and request our data. So we'll start with what is GA-VDRS. We're a surveillance program that collects and analyzes data on violent deaths in the state of Georgia. When we say violent deaths in GA-VDRS, we mean homicides, suicides, accidental firearm deaths, legal intervention deaths, and deaths of undetermined intent. One of the ones that you may not be super familiar with here, legal intervention deaths, those are essentially deaths that involve an authority figure. These are generally mostly populated by officer-involved shootings, and they have their own death banner within GA-VDRS. We are part of the Center for Disease Control and Prevention's National Violent Death Reporting System. All states, as well as Puerto Rico, all participate in VDRS, and we all kind of push, report our data up to CDC, so that data is available at state and national level. The goals of GA-VDRS are to identify burden, patterns, and trends of violent deaths. We provide valuable context on violent deaths in Georgia. We have fairly comprehensive data with GA-VDRS, and that's one thing that we are proud of. We have demographic information, weapons involved, and methods used. We have toxicology results where they're available. We have the locations where the deaths occurred. And we also collect data about events surrounding the violent death, such as, something that may be going on in the victim or victim's life, such as relationship problems, mental health problems and treatment, life stressors, etc. And we'll go through these in more detail when we get to the data elements part, so no stresses. Because I do want to emphasize this last point, something that we really are passionate about in GA-VDRS is improving public health response to violent deaths in Georgia by providing rich and actionable data to stakeholders, whether that be, our community partners or nonprofit organizations, or even other state agencies. So here's kind of our process of how we collect data. We start with death certificate data from our Vital Records office. They send us all death certificates. And what we do is we then kind of parse through and we find all of our violent deaths, which we just spoke about: homicides, suicides, accidental firearms, legal intervention deaths, and deaths of undetermined intent. And then we move forward with the rest of these data sources. So then once we have those deaths isolated, our data abstractors will then communicate with our data reporters, which are medical examiners, as well as coroners and our law enforcement partners. So we get data from medical examiner and coroner reports, police records, and then we have some supplemental data sources as well. We have the supplemental homicide reports that are provided to us from the Georgia Bureau of Investigation. We also have toxicology reports. Those generally come from either GBI or the medical examiner. We have the child fatality review. They actually review and look into deaths that happen in children 17 or under in the state of Georgia, and as well as emergency medical services data. So what the data abstractors do is they take all of those different reports and they pull relevant information, they strip it of any identifying information, and from each source, and they kind of have a template. They have a very specific way. All the abstractors across the nation have very specific and kind of structured ways that they pull this data and they enter it into the database, and that's housed and maintained by CDC's GA-VDRS program. So what data elements does GA-VDRS offer? We have over 1,000 variables, some of them better populated than others, some of them are more like niche variables. So I decided to just kind of talk about the ones that people mostly request, and you're always welcome to reach out and ask for our coding manual that CDC puts out. It's important to remember that, with 1,000 variables, not all of them are well populated, but the ones that I'm discussing here will be, and they are the most common for analysis. So we have demographic variables, the ones that you'll definitely be familiar with, like sex, race, ethnicity, age. And there are some other demographic variables that CDC's GA-VDRS program kind of categorizes as demographics. So that would be marital status, military service, relationship status at the time of death, whether they were homeless or had housing instability. We also have geographic variables. We have county of injury and residency, as well as injury location. So injury location will be a little bit more specific than county of injury. Injury location will be, whether the victim died in their car or their house or their apartment or in a parking garage, a laundromat, things like that. It'll be much more detailed. We have weapon variables. So we have the weapon used. These are some examples of that would be, for example, obviously firearm. We have sharp instrument, we have blunt instrument, poisoning, hanging, suffocation, and strangulation, as well as firearm burns and some other lesser used ones, but the ones I just named are the most common ones. If the weapon is firearm, we do sometimes get detailed firearm information. If we get it, we put it in. We don't always receive it. It's kind of up to, we're kind of at the mercy of whoever is reporting the data on how detailed they are. But some examples, if we did get detailed firearm information, would be something like the make and model of the firearm, maybe the firearm type, whether it was a rifle or a handgun. We would also have some information if it was provided on whether it was stored, loaded, whether the gun was stolen, or we also have information about who the firearm owner was. So was it the victim's firearm? Was it the spouse's the victim's spouse's firearm? Was it, a parent's firearm? We also collect detailed wound information. So what this means is basically if we receive the information, we will plug in where kind of the area of the body where the wounds occurred. So you could see if the person had a wound in their head or their upper extremities, thorax, abdomen, lower extremities. We do record what we call a through and through gunshot wound if the weapon is a firearm. So if the bullet enters one part of the body and exits another part of the body, we actually do record that. So that is available. And this wound information also applies to sharp instrument. So to puncture wounds, essentially. So if it's a sharp instrument, such as a knife and a stabbing, we would also have wound information on that. One of the most, I think, unique and telling things that GA-VDRS collects is what we call circumstantial variables. These are basically variables that describe events surrounding the death. A lot of times these variables will come from basically the interviews that are included in the reports that we receive. So when they talk to the family and they say, yeah, she seemed really depressed yesterday, or yes, she's been on XYZ medication for XYZ mental health issue. Or yeah, he was fired last month and he was really upset about it. Or sometimes the information will come directly from maybe if it was a suicide and a note was left behind. All of these variables come from those types of sources. So I wrote some of them just as an example. There are over 270 of them, but of circumstantial variables. But here are some kind of common ones like job loss, financial problems, current and previous mental health issues, whether they were kind of dealing with something in the court system, legal and criminal problems, were they in an argument prior to the death, or a physical fight, were they having suicidal attempts or ideations. We also record previous suicidal attempts or ideations, not just at the time of death. We also sometimes have perpetrator information. It's very limited because we are victim focused. But an example of when people might ask for this, if you're doing some kind of research on intimate partner violence, maybe you want to know what was the perpetrator's relationship to the victim. People want to know, was it a boyfriend? Was it an ex-spouse? Was it a current spouse? So we do sometimes have limited information on that. We also have incident narratives. That's just a fancy way for saying our abstractors spend a lot of time going through pages and pages of reports from our law enforcement and our coroner and medical examiners, and they pull what's important and they put it basically in a paragraph. There's a structured way that all these abstractors do it. And it's basically a paragraph, and it will kind of sum up everything that they've just read from all the reports. And then we also have toxicology results where applicable. That one's a hit or a miss. It kind of depends on whether they had a reason to test, or a lot of times when the victims go to medical examiner instead of just going from the coroner to the funeral home, they will do a drug panel. So that one can be a hit or miss, but I'm always happy to look into it if anybody is interested. So there are some things to keep in mind when you're interpreting and using GA-VDRS data. As you can imagine, you've seen all those data sources that we have to use. Due to the comprehensive amount of data collected and entered in each incident, we operate around 16 months behind real time. That probably is our biggest limitation, in my opinion. But if you think about, for 2021, we had almost 2,900 deaths. And even if you don't get reports for every single death, which does happen, you're still looking at around 5,000 bare minimum reports that our abstractors have to go through. They have to read everything, and they have to follow the template to enter the data and write their narratives. So it is a ton of work on their part, and we're so appreciative because it's the only way we would have such great data. So complete 2021 data will be available around May 2023. That is when we close out. That is when all of the states close out. So all of NBDRS, all of the states run on the same timeline. And that's another thing to think about as well, is that we are what's called on a decentralized system. So some states are on a centralized system where they kind of just have like one medical examiner maybe for the whole state. And that makes it a lot easier to receive reports. Here we have 159 counties. Medical examiners do take care of the larger counties, but we have coroners everywhere else. And it is completely up to them to report to us. It is not required, it's not mandated. So we really work off of having a rapport and making sure that everybody understands the importance of this. And we always talk a lot about how we protect the data that they're sending it to us and understand what our end goal is. So that's another limitation. We don't always get information past what comes in the death certificate about certain deaths. But that's something to keep in mind. We don't collect data on Georgia residents that die outside the state. So this is unfortunate. It's because it has to do with jurisdiction. Incidents that occur outside of Georgia are difficult to obtain outside of maybe their death certificate. And it's outside of GA-VDRS's jurisdiction. So we can't exactly, if I go to Tennessee and I die, our GA-VDRS team can't call Tennessee's Tennessee VDRS team and be like, hey, can we get her data? That would require a lot of sharing agreements. So we can't collect data on anybody who dies outside of the state, which is a downfall. And so that does lead to the potential discrepancies. I know you guys already had a training on OASIS. It's a wonderful tool. I'm a huge fan of it. And our numbers will vary slightly. And we like to make sure people know that, because OASIS is a little more comprehensive with people who die outside the state of Georgia. But they are a wonderful resource as well for deaths, but the numbers will vary slightly. And our definitions of violent deaths vary slightly as well. So how do I request data and access GA-VDRS data? I will see if this will load for all of us. So we just released our Georgia Violent Death Reporting System dashboard. I'm on a really wide screen, so this may look really small to you guys, and I apologize. But this is directly on our website. I can have Stephanie give you guys the link, or you can just Google Georgia Violent Death Reporting System, DPH, and go to our website. This is linked on our website. This is a really great thing that we've been trying to do for a really long time. Basically, this should help fulfill kind of some of the more basic data requests. You can get your trends, you can get your demographics off of here. We also have weapon information on here.
If you're showing us like the actual thing, we can't see it. Yeah.
Sorry.
Yeah, no worries. Have to reshare. Thank you.
I will do the whole screen one, I think. Screen two should be good. Sure. Okay, how's that? Is that working fine?
Yeah.
Okay, perfect. So this is what I was talking about for like 10 minutes before I realized. I apologize for that. So here you can kind of get your basic data requests. You can look at it by trends across years, demographics. You can look at circumstantial data, and you can also look at the mapping. And each one of these pages kind of has similar drop downs. You can, most of them, you can look at them by overall or sex. You can look at it by EMS district. You can look at it by public health districts. You can adjust it by a death manner. You can adjust it by, age grouping. You can adjust it by race, ethnicity, county, and public health district is down here as well if you wanted to zoom in on a specific public health district. And all of these pages kind of have the same filters. You can also do whatever years you want. We went back to 2016. If you need anything for that, you're always welcome to contact me. You can download the data as well. And you're always welcome to contact me if you see something that you don't or if you don't see what something that you need. This was just to kind of help offload some of the more basic data requests. So can y'all see my power? I went back to the PowerPoint. Is that okay?
Yes, yes, you can.
Okay, perfect. The other one is actually NVDRS, which like I said, is CDC's National Violent Death Reporting System. All the states report up to this. I clicked on it. So you can go here and they have similar data as well. You can change this. You have to agree first. And then it does give you some, this is all of our data just on a CDC platform. And you can change any of this. You would just change this to Georgia. The biggest downfall and the reason that we kind of made our own as well is that you can't go down further than this. So you can't go down to a county level, which a lot of our stakeholders work in specific counties. That was a big reason why we kind of created our own dashboard. And the last way that you can request data from us, especially if you need like line level data, this is our public health information portal for DPH. All you have to do is go to that website, you click make a request, and it's a pretty easy entry form. It's pretty straightforward. You just need to make sure that when you request GA-VDRS data or both FASTER data as well, which is what Don's going to talk about in a minute, make sure you put assign to program chronic disease. I know it's kind of confusing, but we are within the chronic disease and injury program. Otherwise, it'll get routed somewhere else and it'll be really confusing. So just make sure you put chronic here. And the more that you can put in to these data elements and indicators for Adon and I, when you request the data that we're talking about today, the more you can put in here about what you want, the better, because it means we won't email you and ask you what you want as much. So that one's, it's really straightforward, but there are ways to ask questions. There are people at DPH whose specific job is to kind of help you through this. So you can always ask us or ask them as well. And then I don't know if you want to do questions at the end and let Adon go, or if people are welcome to ask questions. Stephanie, it's up to you.
Yeah, we'll let Adon go first, and then we'll have like a collective Q&A at the end. So thank you so much, Elizabeth, for your information on VDRS. And Adon, if you are ready to share, you're more than welcome to share your screen. So thank you so much.
Definitely, thank you. Can anyone hear me, by the way?
Sure can.
Awesome, awesome. All right, so I mean, as usual, awesome presentation, Liz. So good afternoon, everyone, and welcome. I saw a lot of familiar names on the sidebar there. But for those who haven't met me just yet, my name is Adon Oviedo, and I am the firearm injury epidemiologist here at the Georgia Department of Health. I'm really going to be kicking this off by talking a little bit more about the FASTER project, how our data came to be, what we have available. I'd also like to take a small dive into examples of what the data can yield, as well as notes on interpretation and limitations along the way. But to really start things off, I mean, I think it makes the most sense to talk about what the FASTER project even is. As you can see from the title slide here, it stands for the Firearm Injury Surveillance Through Emergency Rooms, and we added the Georgia approach. We say it's the Georgia approach because really this whole project is a competitive 3-year funding opportunity from CDC that was awarded to 10 jurisdictions around the country, each of which have their own approach, which fits their specific needs for their jurisdiction. But on a big picture scale, really this project aims to support states in their efforts to do 2 main things. Number 1 is to improve timeliness of aggregated reporting of emergency department visits for non-fatal firearm injuries, and 2, disseminate those findings to key stakeholders working to prevent or respond to those firearm injuries. So in order to hit that first aim, which was achieving that improved timeliness, a focus on syndromic surveillance was placed. Now, luckily for me, we already had a state syndromic system, which we know as the State Electronic Notifiable Disease System, or SENS for short. This is an in-house statewide system that collects information from emergency departments from all over Georgia and assigns all relevant syndromes to each visit. And we will go into a little bit more detail as to what that looks like and what that means. But currently I have listed here that we have data electronically collected from 150 hospital emergency departments. And I do want to talk about what that means real quick. So we do have 150 facilities currently represented in our firearm injury data. But I mean, as we know, hospitals can open, sometimes they close, sometimes they change names, et cetera, et cetera. And so it's not always easy to keep track of these changes. And to my knowledge, there really is no, standard among the syndromic field. And I would love to be, corrected or enlightened. But I don't believe there's really a standard on how to present these changes and fully address them as they're happening. So when I say here that we have 150, it doesn't necessarily mean that there's 150 currently reporting. It really means that there have been 150 facilities who have reported in our data set up until now. And I do feel like that's a bit of an important note. But in addition to SENS, I would really like to mention the CDC equivalent, which is housed by the National Syndromic Surveillance Program. Because although none of the data that you're going to see here today is pulled directly from their system, which is called Essence, in the field of injury epidemiology, you may have come across publications or presentations talking about firearm injuries. And from the ones that I've seen, these publications typically largely pull data from Essence because it is an awesome program and it is on a national scale. If you're familiar with Essence, you might be thinking, well, what's the real difference between Essence and SENS? I mean, shouldn't they really be the same information since they come from Georgia EDs? And I mean, yeah, you're absolutely right. Because as part of the FASTER program, Georgia does share our ED data with NSSP. But currently we only send information from 115 specific facilities as opposed to the 150 that I mentioned, which is one reason that we chose to move forward with using our SENS system as our primary data source. So having SENS, which is this really awesome tool, the first step in the whole process of this project was the development of that, or the implementation really, of that firearm injury syndrome definition. And here's where I have to give credit where credit is absolutely due. Not only to CDC for all the research that they did developing the syndrome definition, but especially to Bill, Liz, who just presented, and Ashley, who all played key roles ranging from quality reviews to actually incorporating the definition into SENS. On a big picture, what this really resulted in is a syndrome built to function around ICD discharge diagnosis codes and free text from chief complaint fields. And this is for the rapid detection of initial visits with the aim to exclude subsequent encounters, like follow-up visits for cleaning or pain management of the firearm incident. Now, really the cool thing, and again, thanks to Bill on this one, is that this definition was not only incorporated into SENS, but also retroactively applied all the way back to January 1st, 2020, which pretty much means that we can look at this data from present day as far back as 3 years ago. We also do get the question of intent a lot, but as of right now, our system lumps all these intents together, which includes, intentional, unintentional, assault, legal intervention, terrorism, and all undetermined intents. And so, sorry, I lost my place here. But so I guess the question really is, what does this, definition really look like? And what you see here is just an example table of some of the ICD codes that are pretty much flagged for inclusion. This table is much longer and includes a lot of exclusions as well. But the entire query really looks a lot more like this, essentially. The specific query you're looking at right now is the second iteration, hence the V2, which was developed by CDC staff, but also had input from local health departments who conducted manual reviews. I've been spending a lot of time reading through the user manuals and syndromic resources, and it's the inclusion and exclusion criteria. But ultimately, the result was this definition, which provides the frameworks for jurisdictions like us to incorporate into our systems. So that might sound like a lot of effort, really, in terms of firearm injuries, because you would think that a firearm injury is pretty straightforward when it comes to defining it. But when it comes to those text mining methods, there can be some really nuanced and interesting things that pop up. I think Ashley probably knows that better than anyone, being our quality specialist. But I mean, as an example, there's an inclusion term in the chief complaint field, which is got shot, which, as you can imagine, also applies to immunization, as in got a vaccine shot. So if you don't build exclusions that can take that into account, you pretty much get all vaccinations pulled into our definition as well. If anyone's really interested in getting into the weeds of this definition, I do believe it's publicly available, and I think I'm saying that with a relatively healthy amount of hesitation, but I can definitely reach out to CDC and double check. But if we are able to, I mean, I'm definitely more than happy to share this. But in the meantime, let's get on to the good stuff. Let's see what data we actually have available. And so really over the next two slides, I really just listed all the fields we have available. The thing about FASTER is that we are much more limited in the fields we have available because a lot of our information is de-identified. Compared to VDRS, who has a wealth of information, we really have some more basic fields in comparison. And so pretty much I included just about everything, or pretty much everything that I felt was applicable to this group. And so to walk you through column by column, we have the field name to the right, followed by the field type being string, date, or numeric. And then I included a percent completeness and an example of what that field looked like. So to go through the fields, we have our reporting facility, which is a hospital, the triage date, or the date the patient presented to the ED, event tags, which are added when a specific visit meets that syndrome definition, chief complaint, which, as you remember, is a major part of what defines the syndrome, notes on discharge diagnosis, age and years, and the sex of the patient. So while everyone takes a second to really read through the table and sort of soak it in, I do want to take a moment to talk about why I included percent completeness. And as a side note, this percent completeness is calculated as essentially what percent of visits had this field. So looking at ages as an example, 94% of those visits had an age reported in SENS. And so that sort of brings me on to one of the major pros and cons about syndromic data. A major advantage of this data type is that it is readily available. I mean, over 90% of visits in SENS are downloadable within 48 hours of that ED visit. However, the drawback is that not all that information is complete. And it is something to keep in mind as you sort of interpret trends in your data. The demographic information on this table is pretty good, but if everyone has taken a moment to soak it in, I'd like to move on to the next slide to sort of show you what I mean. So in addition to the fields we just saw, we also have, the patient race, the ethnicity, zip code and county, which are based on patient address and not on location of event. The ICD code assigned, which is another major part of the syndrome definition, the medical record number, and sometimes we get triage notes as well. But going back to the percent completeness, when we look at this table, we see that we only have about 3/4 of visits reporting race or zip code, which, as you can imagine, could potentially introduce some bias, especially as you begin to further stratify your data. Unfortunately, there's not really a way to know in which direction. There's not quite enough, to my knowledge, research that would show, especially in the firearm field. But since we are talking about stratification, another important note is that the percent completeness on this table does not reflect syndromic data as a whole. The reason and condition in which a person is presenting to an emergency department is, as you can imagine, highly variable. And so I've noticed that percent completeness is not the same among all syndromes. I actually went ahead and checked these percentages among overall injury emergency departments visits, for example. And I did notice that the data is more complete when we sort of scale up to that level. So with that in mind, yeah, I would love to sort of showcase some figures and tables that that I prepared to sort of get the ball rolling in terms of, data usage and what the FASTER program can provide. So definitely one of the most interesting places to start is, trend over time. I briefly mentioned how excited I am that this data is available all the way back to January 1st, 2020, and that is seen in this chart or this figure. As you can see, the x-axis is set up by month. On the y-axis, our metric of choice for the FASTER program has been percent firearm injuries, which is calculated as the count of firearm injuries over total injury emergency department visits times 100. And you'll note that this is the same metric of choice for the following figures. So really the most notable thing that pops up for me in this graph is that sustained discrepancy between males and females. You notice that females have this remained around that 0.2%, while males have jumped between that 1.2% over the past couple of years. This information is based on the triage date field, which again is when the patient presented to the ED. But if you're looking closely at the tables, you may have also noticed that our triage date does include the time of arrival. And so this is something I kind of wanted to show because this is actually the first time I've generated this figure. And I thought it might be interesting to display. But this is essentially a patient visit over the 24-hour day period for the entire year of 2022. And we can see that the percent of, by percent of all injury visits, we have this pretty steep influx of visits starting, late at night and peaking into the early hours of the morning. To be fair, since we are looking at it by percent, this is partially due to the fact that there are less ED visits during that time in the morning. But I did go ahead and look at this figure by count as well. And we do get somewhat of a similar curve. Unfortunately, I don't have it shown here, but one thing that is definitely consistent is that counts and percentages, between counts and percentages, is that the firearm injuries present themselves in EDs much less during that 7 a.m. to noon, those 7 a.m. and noon hours in the morning, which I thought was pretty interesting. So kind of turning over to geography, Georgia's a pretty big state. We have 159 counties and a lot happens among them. While everyone takes a moment to take this figure in, a quick note on interpretation, we see here that some counties are bright red compared to others. And one thing that I would want to recommend as an improvement on even this map here that I have displayed is maybe it might be better to exclude counts below a certain threshold. Because again, if we're working with percents, a small denominator can quickly escalate that percentage. We also notice slightly higher percent among rural counties compared to non-rural. And really, I would love to take more time to perform more spatial temporal work with the distribution of firearm injuries, but that work would definitely be TBD, and definitely reliant on interest and requests by stakeholders who are interested in addressing this. So kind of moving on to race, what we have here is our sort of comparative bar chart between different races, and of course we see that Black and African American patients are definitely leading in terms of firearm injuries. We again note that huge discrepancy between males and females. But I do want to turn our attention to the second highest category, which might surprise you. And this warrants a little bit of an explanation, but long story short, Rana, our PI, noticed that these counts were pretty high compared to, counts among our Asian patients were pretty high compared to one of our fellow FASTER recipients in a jurisdiction that should have been comparable to Georgia. And so we took a deeper dive on why this might be. And it turns out that half of our counts were actually coming from one specific facility. And so we worked with the jurisdiction, with the district epi, along with the facility where these counts were coming from. And they were both super awesome, super helpful in manually reviewing these. And it turns out that yes, there was an error and that these visits were being sent with an incorrect race label. This has now been corrected as of December 2022. So everything from that month forward will have a more accurate race count. But unfortunately, because it is so difficult to retroactively change data in the syndromic system, 2022 will still reflect these incorrect high counts for our patients who identified as Asian from this facility. But again, it definitely shows that There's constant quality improvement going on, and there are definitely, it definitely would be worthwhile to, sort of check in every once in a while if you're using this data. So here we have a similar figure group by age. And what surprises me here is that, no matter the age group, we sort of still see this discrepancy between male and female. But clear as day, we note that it's really the younger adults who are most affected, that 15 to 35 year age group. And it's very visible. So as a sort of conclusion to the data portion, I just kind of want to take a brief mention here and a sort of sidetrack. But I don't know if anyone here had the chance to attend the Violence Prevention Symposium last month, hosted at Clark Atlanta University. But I think probably one of the most unsurprising things that we're seeing in this data, and personally my main takeaway, is that it's pretty much young Black men who are most affected in this field. And it just seems to be very consistent in the literature that I've read and the presentations I've seen. And so that's just a little something to sort of let simmer and kind of take home while, looking at these figures that were presented here. I think it is very interesting how consistent that finding is again and again. So really to end off, now that we've looked at the data, I sort of wanted to leave everyone off with some notes on limitations. We talked about a couple of interpretation things along the way, but those all important limitations are really important to talk about, because I think we can all agree that all data sets have something to communicate, but it is important to sort of reflect on what can be communicated, but also understand what the data might not be equipped to say. So in these examples, our metric of choice has been percentages among injury ED visits. You might see other metrics used by various FAST recipients, and that's pretty much because, to my knowledge, there's really no fully formed standard just yet. But I do want to point out is that from the literature that I've been reading, my understanding is that syndromic data isn't really meant to characterize this measurable burden of firearm, injuries, but instead, it really is just one tool that should be used to identify trends in conjunction with other data. And that's why I'm so glad that the decision was made to sort of put VDRS and FASTer side by side, because these are just pieces of the puzzle. It really is important to sort of gather the information, look at the strengths of each one, and sort of put the pieces together, which is not an easy task. I'm definitely saying that lightly, but I think we all know that interpretation is such a field in of itself. But in addition, when it comes to syndromic data specifically, there is a really heavy reliance on chief complaint and discharge diagnosis codes. Chief complaint alone can be a field that can be difficult to interpret depending on the wording, and it can really vary from facility to facility, or even staff that was on shift that night could vary. So ultimately, this information is based on this sort of pre-final diagnostic information. So it's important to keep in mind that these systems are expected to have this more moderate sensitivity and positive predictive value when it comes to identifying these cases. So, I keep mentioning the denominator over and over again. And that's pretty much because this denominator is sort of rapidly fluctuating. ED injury visits are not as stable as, the general population, and can change much more rapidly from month to month. I mean, we all definitely saw it during COVID. And so this can have impacts on your calculations. So I just want to mention that because it is something to take into account as you're interpreting your data that you request or have at your disposal. And then lastly, there are a couple of things that we're aware of, but to my knowledge, there isn't really fully a standard way to address them. But I mean, there are certain things like transfers between facilities or individuals who visit facilities outside of Georgia, things like that are something that are sort of good to keep in the back of your mind as well. And none of this is really to scare anyone away from syndromic data at all. At the end of the day, it is a great tool for that near real-time detection of trends, and it is collected every single day. So it definitely has its strengths. But of course, I definitely have to talk about this kind of stuff as well, to sort of, definitely illustrate that it is just a piece of the puzzle, and would highly encourage, that sort of incorporation of all these different, sources that are available. But in order to access our data, I definitely want to encourage everyone to visit our webpage, very similar to what Liz mentioned. And I definitely got to give a shout out to Liz because, wow, her dashboard is really awesome. And I will say that I really, really would like to implement a lot of the really cool things that she and the informatics team did on their dashboard onto this one, because man, there's some really cool stuff on there. But you can see the webpage URL seen pretty much shown here, which you can follow, or you can go to the DPH website and simply type faster in the search bar to find this webpage. But there is currently this interactive dashboard where you can see certain groupings of this information. But at the end of the day, if you have more specific data needs, Liz pretty much already hit the nail on the head when it comes to how to request that data. But you can also definitely please feel free to reach out to me as well. A lot of this data remains largely unexplored, and I really like the data requests that I've received so far because it allows me to look at specific ways that I may have not considered looking at the data before. But more importantly, it signals ways that are useful. And I think ultimately the point is dissemination. I see my job as providing the cleanest, most interpretable data that I can. But at the end of the day, it has to be useful. And I feel like that can really only happen through, individuals like yourselves requesting it and letting me know, how is this most useful and presentable to you. But yeah, with that, I definitely want to say thank you for your time. I really appreciate, everyone who organized this event, and, huge shout out. So thank you so much for that. And thank you all.
Thank you so much, Adon. I do appreciate it. The information that you and Elizabeth provided today is pretty invaluable, and I'm really excited that we are recording it. And so I want to hop into the Q&A and see what questions we have. And we do have one question that specifically says, public health analysts receive de-identified data from SENS, but then we're unable to request medical records from the hospital. So do you have any suggestions on requesting records based on what we see in SENS? And then this person is specifically asking about overdose data. So I'm not sure if either of you are able to participate in that, but we might have somebody on the line that can.
I'm not sure if Rana might be online. If not, then I would say that she's 100% probably the person to speak to. I have not been in a place where I can provide that. I don't think I've really had the ability to approve anything like that. But I think Rana, our PI, would definitely know the answer and would be a lot more have a lot more information.
Sure. Okay. And then everybody can access the slides and recordings. We do have these that are sent out to people that are on the registration list, and then everything can be on the YouTube page for IPRCE. There is a actual playlist with all of the things that we've gone over, and so you can access the recordings there. And we have one more question. So could you describe the difference between a coroner and a medical examiner and how that affects the coding of death versus suicide versus accidental?
Yeah, absolutely. This is quite an interesting topic that we've been talking about lately, and I thought I saw it. Yeah, I see Dr. Kelly here too. So, that's something that we've actually been working with Dr. Kelly with as well. So the difference between a coroner and a medical examiner. So medical examiners are, MDs. So they work as pathologists. And they take care of our larger counties. So GBI has a medical examiner. There's also a Fulton County medical examiner, and there is a DeKalb County medical examiners. They take care of a lot of the bigger counties. And GBI also does some of the smaller counties as well sometimes. Coroners are elected officials. Their really only requirement is, I think, high school education, and they have to be elected. So it is quite a difference in, knowledge in terms of, you just get medical knowledge versus like death investigation knowledge. So they are treated a little bit differently. We appreciate both data sources very much. And I would say in terms of the second half of the question, let me reread it. Suicide versus accidental. Yeah, we were just having this conversation the other day. It's a treacherous path, is all I'm gonna say. I know a lot of times it is really hard to determine between the two if you aren't able to talk to family members or something like that. I know that they usually have to have some pretty concrete evidence that it was suicidal. If somebody dies by a train and nobody could see camera footage or anything like that, it's hard to say whether they were just walking on the tracks and didn't hear it, or if they stepped in front of it. That's a bad example because usually they have, footage and things like that, but hopefully you guys get what I mean. And there have been some instances in the past of stigma on suicide. There will be sometimes family members requesting coroners to not put suicide as the death manner because there is stigma, especially in the small counties, of family members being shocked that this kind of thing has happened in their family. But yeah, we were actually just talking to some of our medical examiner partners the other day, and Dr. Kelly was there, and she's here. So, it's a work in progress, but hopefully that clears everything up.
Yeah, thank you so much, Liz, for going into the nuance of what that has done so far. And that is all that we have for our questions. And so I just wanted to say thank you to Liz and Adon for coming in and helping us understand those data sets a little bit better. And this is our third session of 4. Our next session will be March 22nd. And it's going to go over the BRFSS and the YRBS, so our youth behavior risk surveys and such. And so hopefully everybody will tune in for that one specifically, and we look forward to seeing you next time. So thank you so much, and I hope everybody has a great day.